Hello and welcome to our circulation imaging case webinar series. Thank you all for your interest and for joining. The webinar is organized by Circulation Cardiovascular Imaging, Professor Renee Bullock-Palmer and Professor Ahmad Masri, as well as myself, Inga Voges, will be the moderators, and we have two interesting case presentations that will show you the value of cardiac imaging, how we can guide structural interventions and myocardial biopsy. And I will give the floor to Renee. But before, I would like to remind you that you can put your questions into the Q&A, and we will have enough time to discuss them later on.
Good afternoon, everyone. Thank you, Inga, for introducing the webinar. So we have our first case, which is going to be presented by Drs. Sato and Mori. It will be a case titled Intermediate Accessory Papillary Muscle and Anatomic Variant of Interest for Transcatheter Edge-to-Edge Mitral Valve Repair. And then we're joined this afternoon by our expert panelists, Dr. Nazer, Dr. Raimondi, and Dr. Safi. So I'll just introduce each of them. So Dr. Nazer is an electrophysiologist and associate professor of medicine and bioengineering at University of Washington, where he runs the multidisciplinary ventricular arrhythmia program and also the translational EP laboratory. His research focuses on medical device development for the treatment of VT and hypertrophic cardiomyopathy. And he also has clinical research on the overlap between inflammatory and genetic cardiomyopathies. Dr. Lucy Safi, she's an assistant professor of medicine at Icahn School of Medicine at Mount Sinai, and currently works as an electroechocardiographer and an interventional echocardiographer at the Mount Sinai Hospital. She completed fellowship at Cooper University Hospital and then advanced echocardiography fellowship at Mass General. And her focus is on valvular heart disease and structural heart imaging and AI in echo. And our last panelist is Dr. Raimondi, who's a pediatric cardiologist and an expert in non-invasive cardiac imaging in fetal echo, adult echo, CT scan, and cardiac MRI. She directs the director of pediatric adult and pediatric congenital heart disease unit in Bergamo, and also has had over 10 years of experience. And she's a board member of CMR. So we're happy to have all three of you guys here, and I invite Dr. Sato and Dr. Mori to start presenting their case. Thank you.
Okay, thank you for having us today. Today, I'd like to share images of the intermediate accessory papillary muscle, which is relevant to transcatheter edge-to-edge mitral valve repair. The left ventricular papillary muscle projects a caudate to the lateral and medial parts of the mitral reflex. However, generally, these caudae don't support the central edges of the reflex. This creates a central caudate-free zone, which allows safe access to introduce and deploy the mitral clip in this region. Here, let's dive into the left ventricle through the mitral valve. You can see the oblique orifice of the mitral valve. Each papillary muscle is located beneath each commissure, giving caudate to the lateral and medial side of the reflex. When viewing from the left ventricular apex, you can clearly see the same relationship within the papillary muscle and the commissures. I mean, the lateral one gives caudate to the lateral commissure and the lateral parts of each reflex, and medial to the medial commissure and medial part of each reflex. As a result, here, you can see central caudate-free zone in both mitral reflex. One in the anterior mitral reflex is a bit longer though. This caudate-free zone is where captured by mitral clips. However, this is what we found in the heart rejected for transplantation. Here, each papillary muscle shows 3 heads, number 1 to number 3, and number 5 to number 7. Interestingly, between them, you can see the additional papillary muscle projecting the caudate to the center of the middle scalp of the posterior mitral leaflet. This is referred to as the inferolateral intermediate accessory papillary muscle. These are the CT images reconstructed from the same heart. In the volume rendered image viewed from the RAO direction, you can see this accessory papillary muscle between both regular papillary muscle. MPR short axis image is useful to confirm that accessory papillary muscle is located in the inferolateral segment of the left ventricle. Dr. McAlpine already described this particular anatomical variant. We can see similar accessory papillary muscle between regular papillary muscle, and it gives caudae to the center of the posterior mitral leaflet. From our review of the donated hearts, in the inferolateral intermediate accessory papillary muscle is not a rare variant. It shows up in about 30% of cases. However, further research is needed to understand how common it is in clinical practice. We'd like to discuss about the clinical implication of this particular accessory papillary muscle. This study shows safety and efficacy of the mitral clip implantation in non-central position. However, in such non-central implantation, mitral clip can be entangled by the caudae jungle, which can lead to caudal rupture. At least, such lateral non-central implantation requires careful procedure with a consideration to reach caudae network beneath the valve, which cannot be readily observed with clinical imaging. This is a real dissection photo of another heart without accessory papillary muscle who has two mitral clips. As you can see, there is a dense network of caudae in both medial and lateral side. The central clip is positioned in the central caudae-free zone, which effectively captured both leaflet edges without interfering with caudae. However, the medial clip is surrounded by multiple caudae as it is placed outside the central caudae-free zone. This medial clip placed outside the central caudae-free zone failed to capture the posterior mitral leaflet, resulting in the single leaflet capture. Therefore, caudae is important. However, visualization and appreciation of the caudae with clinical imaging remain challenging. Here, upper panels are cased with intermediate accessory papillary muscle and lower are control case. If you find inferolateral intermediate accessory papillary muscle, it can tell you the potential existence of central caudae projecting to the center of the posterior mitral leaflet. This intermediate accessory papillary muscle may complicate mitral clip implantation even in regular central zone of apposition. To detect inferolateral intermediate accessory papillary muscle, we recommend careful observation of the left ventricular short axis and volume rendered image from the RAO view. Observation solely based on actual image can miss the structure. In conclusion, we described the cadaveric observation of the inferolateral intermediate accessory papillary muscle. Its existence suggests extra caudae in the central zone of apposition, which may complicate the transcatheter H2H mitral valve repair. Thank you very much for your attention.
Thanks for that great presentation. Dr. Mori was the co-author. Did you have anything to add to the presentation before we ask our panelists?
Just to like to share this interesting anatomy, which is not that familiar with regular cardiologists, and we are now happy to have any question and discussions.
Great. So Dr. Safi, I know this is your bread and butter with interventional echo. So what are your thoughts? And did you have any questions for the authors?
Yes, thank you. I think this was a very, very interesting paper, very well done by the author. So thank you for this very important topic. You know, when we do an edge-to-edge repair, knowing where the chordae are is extremely important because it does help identify potential complications during the procedure. And so, as you mentioned in your paper, it's not uncommon that you can have accessory papillary muscles and therefore accessory chordae. So when we are doing an edge-to-edge repair in the lab, one of the very first things we do is actually we use 3D echo and biplane imaging to sweep through the mitral valve leaflets. And the purpose of that is to identify where all the chordae are. And then that way, when we are clipping, we do try to make sure that we don't go in that area unless we have to, so we can avoid entanglement. It is very uncommon to have cords in the central location, the A2P2 area, which you are describing in your paper. But you can have them, especially in patients like yours, and also in patients with redundant leaflets, Barlow's disease, you can have them. And so it doesn't prohibit you from doing a mitral clip procedure on these patients. You can clip next to the chordae. You can actually even clip the leaflet adjacent to the chordae. But you want to try to avoid clipping the cords themselves. So I think it's a great, well done paper. You know, my question is, in your paper, you did say that you've seen it, and you quoted a number up to about a little over 30% of the cadaver patients, you know, had this interesting anatomy. It seems higher than I would have expected. You know, what are your thoughts on that number? I think you said about 36% of the patients that you investigated had an accessory papillary muscle and chordae.
Yeah, thank you for your question. So actually, we are also surprised that that is not so rare. So that is higher than I expected. So we just observed only 35 hearts so far. So we found that frequency that is 30%. So, but we have to check, we need to check such a CT data or echo data in the clinical practice to find accurate, and yeah, we need more data, I think.
So Dr. Safi, have you come across any of these cases in your practice?
Yes, I think you know, we have seen patients with accessory muscles and accessory chordae, and you know, I can't stress the importance of doing pre-procedural imaging in these patients. You don't necessarily need a CT, but what you do need is a careful echo in order to try to see if you can identify them. And you know, one thing I learned from this paper is that if you do see chordae attached to a location that's unusual, such as the A2 or the P2 central area, then perhaps you need to dig further and see, is there an accessory papillary muscle? So kind of work backwards. If you see the cords, look for the pap. And I wonder that if we start to do that, how many more of these accessory papillary muscles will we identify?
So I'm thinking that's probably is under-recognized, you know. But you know, with the edge-to-edge clips that we use, you know, is there any particular approach that you would take if you came across such anatomy in the cath lab, like the types of clips, the approach? How would you plan the procedure?
Mm-hmm. Yeah, so if we needed to clip a patient with accessory chordae, what we'll do is identify first where the location of the leak is. And if we can stay away from the cords, that will be our first and most important technique. But if we are forced to clip near the chordae, it's not uncommon that we would want to go in with the clip closed and open just under the leaflets themselves. And the reason why we would want to do that is so that if you don't go too deep with the clip when you're bringing it in, then you'll reduce the risk of entanglement. So if you just bring in the clip as needed into the ventricle, open just below the leaflet tips and then grasp, you'll reduce the risk of chordal injury and entanglement. So that's one of the techniques that we will do. And again, when we're sweeping through the valve in the pre-procedural setting, we like to measure the leaflet length. And if we see that a cord is inserting to the leaflet tip, then we know that grasping in that area is unlikely. And so we'll try to find an area just adjacent to it, but still in the location of the jet that we can grasp safely.
And I know in the procedure itself, when we're doing 3D, we usually look from the atria down. In these type of cases, is there any benefit from looking from below the valve itself to see where the chordae are when they're inserting the clips?
Yes, I think that's a very, very good technique that you can do. So the thing with a 3D volume set is it gives you the opportunity to look both from the atrial side and the ventricular side. So it's not uncommon that I will rotate the 3D volume set and look at the bottom, and you can actually reduce your gains and get rid of all the artifacts. And you can take a look at how the leaflets look from the bottom, so from the LV side up. And that will help confirm if there are chordae there and exactly what the bulk of the chordae look like. So yes, we do that, and that will help locate where the regurgitant jet is as well.
Right. Did any of the other panelists have any thoughts on the case? I know it might be a little bit out of your area of expertise. Dr. Nazer, Dr. Raimondi?
I have a question and wonder if I've seen a lot of these on intracardiac echo at the time of papillary muscle PVC ablation, and maybe my head has just said, oh, it might just be a really broad posteromedial pap or a really broad anterolateral pap. So it's encouraged me to be a little more detail-oriented in my intraprocedural imaging, which is ICE. But I guess my question for Dr. Mori, I know most of your work is within the EP group at UCLA. Do we think this accessory PAP could be arrhythmogenic, aka if you have one, you're more likely to have a PAP PVC?
Thank you for the question. That's the one that is very difficult to answer. But I don't think there's a specific case report that presenting the ventricular arrhythmia specifically originating from this type of accessory papillary muscle. And here the problem is even the definition of the accessory papillary muscle is quite variable among authors. Someone just called the accessory head as accessory papillary muscle, but someone called like the one like we presented as accessory papillary muscle. So it's about we need to define the accessory papillary muscle at first. And from the anatomical standpoint of view, we think generally the papillary muscle is originated from inferior segment and anterolateral segment. So anything originated outside from that segment, I think we can say that is accessory papillary muscle. That is the reason we focus on the inferior lateral region, which is a general accessory papillary muscle free. And in terms of inferior lateral segment, the many inflammatory myocardial diseases, the inferior lateral segment is a frequent site of inflammation. So in that meaning, it can be arrhythmogenic, I think. Thank you very much.
Yes, thank you.
Dr. Raimondi, I know you have some experience in pediatric cardiology. What are your thoughts, and have you come across these cases?
Yeah, I have a question. So knowing that you are assuming so that this kind of variant is much more present than previewed, actually, do you think it would be important to have a model and non-invasive imaging model before your procedure just to reconstruct exactly the anatomy of all chordae and papillary muscle?
Like a 3D model, you're thinking?
A 3D model.
Yeah, that's also another important point. As we presented, it is very easy to miss this papillary muscle, whether like just a scrolling the actual images of the CT, or if we are not careful enough, or if we are not have a knowledge of this papillary muscle. So very easy to misstructure, but we recommend that at least we should check the short axis image with echo or with CT, with MRI, very carefully, and anything outside from the inferior or anterolateral segment should be referred to as accessory papillary muscle. And regarding the chordae, here I have a question. So from the anatomical standpoint of view, there's a multiple classification of the chordae. The one is of course attaching to the margin of the leaflet, and another one is attaching to the belly of the leaflet. And unfortunately, the one attaching to the leaflet is generally thinner than the one attaching to the belly of the leaflet. And the general thickness of the chordae is like a 0.25 to 1.75 millimeter. So my question is to Dr. Lucy, if you're using the intraoperative echocardiography, either TEE or ICE, do you think that imaging can readily recognize all of these chordae, even if it is thinner than 0.5 millimeter?
Yeah, I think so. We have to understand what we are trying to do with an edge-to-edge repair. So when we're doing an edge-to-edge repair, we grasp the leaflet tips. And so if there is a chordae at the body or the belly of the leaflet, it generally is not in the way. Unless the only time it would get in the way is if you bring the clip into the ventricle too deep, and then you can get entangled. So it's rare that we bring in the clip that deep into the ventricle that we would get entangled. So we're focusing mainly on the leaflet tip. So it would be the thinner chordae that you are referencing. And in that case, when we sweep through with our echo, we're able to see the ones that would potentially be in our way. So, we do clip predominantly at A2P2, but we also do put clips in the other segments of the mitral valve, so more medial or more lateral where there are cords. And so generally with those clips, we just bring them in very carefully and with the technique that I described earlier where we don't go too deep. But to answer your question, even if they are there, the bigger prominent chordae, we just do our best to stay away from them.
I see. So basically you can miss the really thin chordae.
Mm-hmm. We can miss the really thin chordae, but if they're that thin, they may or may not cause issues with the clip itself.
Makes sense. Yeah, I'm familiar with the CT and the MRI, and I'm pretty much sure that I am missing some of the chordae because it is under the spatial resolution.
Mm.
And I was wondering, Dr. Safi, as you're just talking just now, so when you have, if you have the cases where you have the chordae attached to the belly of the leaflet, would you preferably use an NT, a smaller clip, rather than an XT, which has a longer arms?
It depends on the leaflet length as well. So it depends on the integrity of the leaflet. So we need at least 7 millimeters for the NT and 9 millimeters for the XT. And so if we don't have enough leaflet length, then we will use the smaller NT clip. So that's all, that is all considered when we're screening through the valve. And, if there is a cord that inserts closer to the tip, and that's where we have to grasp because that's where the regurgitation is. If it's about, 7 millimeters of healthy tissue, then we'll switch to the smaller clip.
And do you sometimes use ICE in these cases, or do you do just 3DT?
For a mitral edge-to-edge repair, we typically just use 3DT. Mm-hmm.
Yeah, that's what I thought, because I know I don't think many places, if any, are using ICE at this time, right?
I believe there's been some case reports, but it's not standard of care.
Yeah. All right. Well, thank you. Any other last thoughts, comments from my other co-editors, Dr. Voges, Dr. Masri, Inga, Ahmad?
So I was wondering if there is already any knowledge about the actually about the significance of this accessory papillary muscle. So how often do we actually see important or significant complications when doing the mitral clip procedure?
Dr. Safi, do you want to answer that?
I don't know if we know that data. You know, I think that when we're doing these edge-to-edge repair procedures, you know, to be honest, I'm not sure that we are assessing whether or not there is accessory papillary muscles. We're focusing more so on the cords themselves. And so perhaps maybe that could be a secondary investigation or study where we do start to look at those things. But I think, you know, one of the great teaching points for this paper is that, you know, if you do see these cords that are attached in a various or an accessory area, perhaps, you know, you should do that second step and look and see if there is an accessory papillary muscle as well.
Yeah, actually, there's a very old data that's showing that accessory papillary muscle is related to mitral valve prolapse or like a sudden cardiac death, but it will need validation in this era. Yeah, thanks so much.
All right, Ahmad, any questions before I turn it over to you?
No, thank you. Great discussion.
Great, thank you. So over to you for the next case.
Thank you all again. This has been really an excellent discussion. We're very happy to have Dr. Barone-Rochette with us. He's a professor of interventional cardiology and cardiology, specializes in coronary artery disease as well at the Hospital University of Grenoble in France. This case I thought was fascinating because it does focus on a new method where it can use hybrid CMR guidance to look for endomyocardial biopsy in patients who are suspected to have cardiac sarcoidosis. So without further ado, I'll turn it over to you.
Thank you very much. It's a great pleasure today to talk about the new method of CMR-guided endomyocardial biopsy in suspicion of cardiac or isolated cardiac sarcoidosis. So the case is young people in 2020, young girls presented a cardiac arrest due to ventricular fibrillation. Initial investigation showed ECG revealed right branch blank, elevated out of troponin. Echocardiogram is normal, but just with a septal hypokinesia, and invasive coronary angiogram with pharmacological test, it was normal. CMR is really important with different sequence. With a cine, we can see effectively the hypokinesia in a small area. In exactly the same small area, the T2 mapping is abnormal. It's little hyperemia, but it's difficult to see the first pass perfusion. And finally, in a lateral enhancement, you can see abnormal area in a septal too. That is really interesting because we decide to perform a PET-CT FDG, and you find exactly the same abnormal area with the inflammatory or abnormal uptake of FDG, and without other site of area in the body of the patient abnormal. Initial investigation concluded in to be a case of myocarditis, but the uncommon pattern of left gadolinium enhancement, the presentation, clinical presentation, finally we decided to perform or program a new evaluation was planned after 6 months due to rule out cardiac sarcoidosis by the new PET FDG. Nonetheless, subsequent clinical assessment was not performed, and the patient mild without symptom until 2022, when she encountered a new episode of arrhythmia to lead to appropriate shock. A radiofrequency endocavity ablation at the right ventricle was performed without the area causing the arrhythmia being clearly identified. And finally, we decided to perform a new PET FDG, with revealed exactly the same result of the first, with abnormal uptake of FDG on septal and no other uptake in the body. the diagnosis of isolated cardiac sarcoidosis and it's suspected, and finally endomyocardial biopsy was necessary to finally identify the disease, but in the small abnormal area identified by left gadolinium enhancement and PET CT image. Finally, to help the performance of the endomyocardial biopsy, my center, with the different collaboration of laboratory, developed a specific new technique. We used a preoperative CMR after you finally use with automatic segmentation with a left gadolinium enhancement image, a combination of 2D UNet and UNet transformer to finally obtain a automatic modelization of the ventricle. And for the moment, because you use this technology for small area of left gadolinium enhancement, the abnormal left gadolinium enhancement is for the moment pointed by manual segmentation. And with that, you can obtain a real model, a 3D model of the disease. And after, for the procedure, it's simple. First, the beginning, you perform a ventriculography with different view. And with this view, you can finally identify the morphology and the geometry of the heart. It's possible before the intervention to choose the access way. For example, right access or right or left access with different device. For this patient, you decide, because it's left gadolinium enhancement transmural in a septal view, you decide to use a simple right access, but for the good orientation, you decide to practice a ventriculography by femoral access. And finally, you perform the biopsy. And it's made with finally the model. You can move the model in the same projection of the C-arm. It's interesting for understand the geometry of the heart. And finally, for this patient, the anatomopathologists show no inflammatory element in favor of chronic myocarditis and no caseating granulomas in favor of sarcoidosis. But effectively, regular cardiomyocyte and some anisokaryosis existed. And finally, you identify a desmosomal gene-related arrhythmologic left ventricular cardiomyopathy was pointed out. So to take a message, it existed effectively a strong overlap between myocarditis, desmosomal gene-related arrhythmologic cardiomyopathy, and isolated cardiac sarcoidosis. But the treatment for the different diseases is not the same. It's for certain, it's clear to use immunomodulation, for other no. In patient having no extracardiac disease upon whole body FDG PET. Finally, endomyocardial biopsy is necessary to confirm cardiac sarcoidosis. However, in this case, the endomyocardial biopsy was low sensibility, particularly due to its focal nature. And in this context, finally, new method CMR-guided endomyocardial biopsy can improve accuracy, but for the moment it's not perfect, so it's not totally automatically, but it's in progress. And I use this element for different patients, and that is one of case of my experience. Thank you very much for your attention.
Excellent. Thank you so much. We have a great panel here who can help us digest this some more. I'll start with Dr. Nazer. Dr. Nazer is an electrophysiologist, but he also focuses on cardiac sarcoidosis. He does lots of endomyocardial biopsies, and we together have reviewed many MRIs before. So I'll turn it over to you first if you have any comments and any questions.
Yeah, I think it's a beautiful paper, Dr. Barone-Rochette. You and your co-authors should be commended. A few of your takeaway points that I want to hammer home for the audience, especially any trainees, are notice that the investigators and clinicians did not label this patient with sarcoidosis simply based on PET. We too often see this, at least in my and Ahmad's community, patients simply getting labeled as isolated cardiac sarcoidosis. And sometimes these patients will meet at least the Japanese version of the sarcoidosis guidelines, but without any further investigation and no biopsy. So you're to be commended for going the lengths of not only getting a biopsy, but getting such a detailed image-guided one. Our European colleagues do a much better job at biopsying cardiomyopathies and myocarditis than we do. The second takeaway point that you made, and I want to reinforce, is that 12% of patients presenting with myocarditis will have a genetic background, a pathogenic variant. And the Circulation family of journals has been really, I think, instrumental. A few papers that I cite to my trainees that I'll put in the Q&A here for everyone to see are from the Circulation group of journals, and sort of defining this overlap between inflammatory and genetic cardiomyopathies. I'll put it in the chat, but if we can share it with everyone, that would be good. A couple of questions for you about this great case. You mentioned the patient had gone for a VT ablation, which usually includes electroanatomic mapping. Can you share, did the mapping show any low voltage zones? And I ask that because the way we perform our biopsies is a voltage-guided biopsy approach, where we do the same mapping we would do for VT ablation, but instead of ablating VT, we would just take the biopsy. I'd love to know more details on the EP part of this case.
Thank you very much for this question. It's really funny because you talk about the mapping, electro mapping, or for example, for the NOGA, because the beginning of the development of the fusion imaging, it's for the cell therapy. And in my institution, finally, the NOGA, it's stopped by Janssen & Janssen, and you decided to develop all the way with a biocardia, with the helix, and you use finally the all imaging information, because finally the validation of the NOGA was performed by CMR and TEP and imaging information. And you decide finally to take all information of the imaging to create a same information. And finally, you decided to don't use the mapping and the electro mapping, but effectively it's the other solution. Other colleague of me in Nantes developed other system with like Rhythmologia. But in my institution, we decide finally to use a simple device for the injection, for the biopsy, but no device with a sophisticated technology to mapping or to other system. But effectively, the two solutions is possible. For the moment, it's really the capacity of the pre-operative imaging to accumulate this information, because probably with deep learning and for the modelization, etc., in my opinion, it's a really future development of this element.
Yeah, I totally agree. The other thing I wanted to commend you on was your group used this CAMI-TK open source image processing software, which I learned about through reviewing your paper. And that's really cool. There are two companies out there that are doing this commercially. One is InHeart, actually a company started out of Bordeaux, which I looked on Google Maps is 1 hour and 42-minute drive from your institution. That's a product called Music that they do this, but at a cost. And the other one is a company called ADAS out of Spain. I don't have a conflict of interest with either of these two companies. But I think the beautiful thing you did is you did it yourself using open source software. So yeah, I think my feedback, the next level for this excellent technology is to take the pre-procedure imaging, but instead of merging it with a left ventriculogram, which adds arterial access and a little bit of risk, acknowledging those aren't too hard to do, you could merge this beautiful approach you've taken with an electroanatomic voltage map, kind of like the one your patient had at the VT ablation. And the one benefit there is it gets past the temporal relationship. We know inflammation comes and goes, and there's ultimately a lag time from when the MRI and the PET were done and the patient comes for biopsy. So the beauty is that the map tells you what the tissue architecture looks like on that day. And then the last part would be the use of steerable sheaths. You ultimately, from the neck, get limited to that fixed curve sheath that you showed beautifully in your image. But in the EP lab, we use steerable sheaths that really allows us to, at least in the two-dimensional format, go around there. So a beautiful case, and I put 2 links in the chat for what I think would be great next steps to build on what you've already beautifully started.
Yeah, the image is in progress, but currently I have a difficulty for the certain biopsy for the left ventricle for sarcoidosis or myocarditis, because the orientation of the system is not adapted. I try to discuss with different company for specific finally device. For the moment, with 7 French prone, you can, but the orientation is not perfect. It's a difficulty for the moment.
Yeah, for left ventricle, we usually try to combine it with someone on whom we're doing a left ventricular ablation anyway, to combine risk for 2 and 1. But we do some standalone, and we use the same steerable sheaths, transeptal access to the LV that we use for ablation, but instead we put a bioptome and connect it to the same mapping system. And with that, you can actually guide the bioptome on the mapping system to the areas that you had previously identified as low voltage and sick. Yield is still not perfect. You mentioned that depth issue. If the inflammation is more than 5 millimeters deep, the biopsy is not going to grab it.
The real aim is a complete fusion with a real anatomic fusion with diastolic and systolic, but it's the other step probably.
Thank you for this rich discussion. It's really an important clinical takeaway is that and this has been published on many times, for quote unquote isolated cardiac sarcoidosis, you really have to think about other explanations and other potential genetic cardiomyopathies, which then I would turn it to Dr. Francesca Raimondi in the sense of you've seen the MRI pictures. What would run through your head, when you see somebody like that with an MRI picture, and what did you think about the CMR that was shown?
Thank you. Yeah, I was just ready for the comment. Actually, in children, just to also reconnect to what was saying before, in children, actually, we pretty acquitted to do biopsy. Biopsy is just really related to really weird cases or really special cases, especially for fulminant myocarditis or refractory heart failure, when you have to decide if go on or not, But normally we use MRI as a virtual biopsy. Going deeply, so in the subject, actually, images are really suggestive of, you can really differentiate the different types of myocarditis and also arrhythmogenic cardiomyopathies. I put in the chat now for panelists a paper that we published it 2 years ago, is intercontinental United States and Europe multi-center study that we did after the observation that a lot of adolescents with recurrent myocarditis and familiar history of myocarditis, actually they were positive for genetic panel of desmoplakin, especially so arrhythmogenic left ventricular cardiomyopathy. But the MRI pattern, just to answer to your question, is really specific. So this trial that we published, it actually was really the product of an observation, because we observed that specific LG pattern in acute myocarditis were suggestive of arrhythmogenic cardiomyopathies. So it's a ring-like artifact, LG aspect, and you really can see in the paper the images. So the typical myocarditis pattern as subepicardial actually inflammation of the inferior lateral wall, it's not at all related to genetic mutation if you have just this pattern. You have to have other LG intramyocardial, first of all, should be multi-segment, and especially in the septum and also anterior part. And with this ring-like aspect in the entire intramyocardium. And if you do the history, there is a really high prevalence on family history of recurrency of myocarditis. in the patients or in the family. Another typical aspect, when I saw these cases, actually, I did not think at all at arrhythmogenic cardiomyopathy because it's not at all a typical aspect. You never have an LG in one segment in arrhythmogenic cardiomyopathies. And also in myocarditis, in children, also we published some years ago, one of the biggest pediatric series of myocarditis studied by MRI and also with follow-up MRI, so at 1 year and 2 years after myocarditis. And we demonstrated that actually in children, there is the possibility to have a transmural pattern as more or less in this patient, but it's extremely rare. It exists, but when exists, is never in one segment. It's always multi-segment and is associated with severe myocarditis, often with heart failure or even necessity of assistance in multi-segment late announcement. And normally it's associated with not recovery of ejection fraction in prognosis. So when I saw this aspect, actually, I did not think neither myocarditis, neither arrhythmogenic cardiomyopathy, actually.
That's a great point, which speaks why I think ultimately we really have to be careful with making these presumptive diagnoses, especially in isolation, from sarcoid to other things. There was a paper, when I worked with Dr. Nazer together, we had a paper on, these exact cases where you can sometimes be safe, even if you don't have access to the expertise of doing, targeted endomyocardial biopsies, even if that's not something you can do. At least if you have isolated cardiac sarcoid that wasn't biopsy proven, you could consider looking at genetic variants. And while they don't capture every single patient, they at least keep you safe for the majority of these very clear pathogenic and likely pathogenic variants. And so that's something that one can consider incorporating into their practice, where if they don't have the expertise available to do thorough evaluation up front, they could also check for pathogenic, likely pathogenic variants. But it goes back to the same story, is that these variants could be common sometimes in the community. And you really have to have the right picture, a presentation phenotype to correlate. I'm going to open it up to my colleagues, co-moderators, and everyone on the webinar to see if they have any comments or any questions.
Can I ask a question? Sorry. This is an excellent presentation, and I really love this kind of image-based logical safe approach, which is an anatomy-based approach. And my question is, the specific region of this case, why it looks like a distal part of the septal marginal trabeculations, where it gives rise of the moderate advance. So my question, I was just curious whether this case already have, or right after biopsy, you may observe the right bundle branch block.
Effectively, she presented a right branch. I don't know exactly why it's really a short area, but finally you decided to perform a biopsy, and it's okay. But I don't know. When the rhythmology performs the electromapping for the second appropriate choke, finally the evaluation is really strange. The rhythmologist don't understand, and they are not only the septum and the area abnormal for my colleague rhythmology of rhythmology. All right ventricle are abnormality in a mapping. But finally, with the image, you have an area in the septal, and decided to biopsy with the information.
I'm just asking, did you observe right bundle branch block in this case?
Yeah.
Yes. Okay.
Yeah.
Thanks so much.
Any other comments?
Just a question. I think, there's significant overlap and challenge when it comes to the clinical presentation of these young patients. And, you know, they come in with arrhythmia and you know, for future patients and clinically, you know, what would be your workup? You know, if you had to do it again, how would you work up a patient like this?
If a new patient with the same presentation? Effectively, the question is, it's necessary to practice the biopsy or to finally await the result of the genetic. That is the element, because now you know finally a lot of cardiomyopathy with a genetic variant can present the evolution with inflammatory. It's really a link. But the genetic is not quick for a lot of patients. For the moment, and the other element, you can have a genetic not really concurrent with a variant, no really with a strong correlation with the phenotype. And in my experience, finally, it's difficult to decide with if you have a negative biopsy or negative anatomopathology or positive, or it's more easy to decide, because the problem is the other colleague of me decide when you have a patient with a myocarditis, abnormal PET, and after the phase, acute phase, he decide to put corticoid without proof of the disease and follow the patient. My colleague internist is not agree with this position, because it's difficult to put a corticoid in a people, and finally you say, oh, it's okay, it's not okay. And after, if you have not a great response answer, finally you must change the immunomodulation. It's really difficult, in my opinion, to practice that without a clear diagnosis. And when I say there's an overlap between the different disease, finally there's an overlap of the clinical presentation, but for the strategy of diagnosis and treatment, this is not the case. For example, for the sarcoidosis, you must begin with a corticoid, and after 6 months, you have perform a new re-evaluation with a PET, and in function of the result, you can change the. It's really clear. After, if you have chronic myocarditis, the immunomodulation is more. It's not also clear, and in my opinion, it's really and in myocarditis you can have a really overlap with the genetic evolution of the chronic myocarditis. And in my opinion, it's really better to have all information, genetic and anatomopathology, because genetic is not really also clear.
That's just curious. That's just curious, Dr. Rochette. How rare is these cases of isolated cardiac sarcoidosis? Because I mean, these cases are pretty rare, right? To have just an isolated case in a discrete area of the heart.
Yeah. As this case, can you repeat the
I'm just
question?
wondering how rare are these cases of isolated cardiac sarcoidosis? I mean, it's very rare that you come across these cases clinically, right? Oftentimes they're involving the pulmonary involvement as well as the heart.
Yeah. The real prevalence of the isolated cardiac sarcoidosis is not really known. And effectively, the case more simple. It's systematic sarcoidosis, and with just abnormal image of cardiac image. That is really simple. But a lot of, in my experience, for example, you follow a patient with a long time with CMR, with effectively patchy left gadolinium enhancement, but the interpretation of my team, it's dilated cardiomyopathy. And the follow-up, it's okay. And the follow-up is not good. And finally, you decided to transplant the patient. And when you analyze this, and this is why I am really afraid to don't see a case of sarcoidosis because in my experience, finally, and I have a good experience of the CMR, but for certain cases, it's not also clear. And this is why the follow-up of the patient and finally the evolution, arrhythmia, strange movement of the wall muscle, all elements strange. Now finally it's element to program a specific modelization for a endomyocardial biopsy. It's due to my experience because I follow patient and finally I don't see an isolated cardiomyopathy with finally a severe. I don't know if I perform the diagnostic in the beginning and with the immunomodulation finally the degradation of the muscle disappear, but for this patient I don't see the disease and finally the evolution is the transplantation.
Yeah, I agree with that. It's hard to answer that prevalence question of isolated cardiac sarcoidosis because of the misdiagnosis. Dr. Masri and I have a colleague at his institution, my former one, Dr. Ben Levin, who says this great quote: cardiac sarcoidosis is both overdiagnosed and underdiagnosed. And probably among the pulmonary and systemic sarcoidosis patients, it's underdiagnosed. Many of our non-cardiology peers probably aren't looking enough for cardiac involvement when there's already lung involvement. But this isolated cardiac sarcoidosis is vastly overdiagnosed, probably not necessarily at our peer institutions, but because we deal with it so frequently. But we've been educating the rest of the cardiology community to think a FDG avidity on a PET scan equals inflammation. So you can't fault them when they make the natural leap to call things sarcoidosis. So we have to now have the duty to do some uneducating about the fact that not all FDG avidity is inflammation and definitely is not always cardiac sarcoidosis. And I agree, we see this in run-of-the-mill DCM, where we see FDG avidity. I have some hypotheses about why it might actually be myocardial glucose utilization and not inflammatory infiltrates we're studying here at our center. So I can't underimpress the value of biopsy and frankly genetic testing. And I guess I'll ask Gilles, if you had the pathogenic variant in desmoplakin come back earlier, would you have still biopsied this patient, or do you feel that's sufficient to say this is clearly this myocarditis secondary genetic architecture? Would you still have biopsied the patient if the genetic testing had come back earlier?
Depends on the case. Effectively, when you have a doubt, finally you perform the and the other element of the discussion for the programmation of the biopsy is the localization of the. For example, when you have the circle left gadolinium enhancement circle in a epicardial, finally the performance of the biopsy is not perfect in my opinion. In left ventricle, and finally for this case, for example, I don't really sure of my result of my biopsy, and finally in this case I wait the genetic and I can perform a follow-up, but it depends of the finally the safety or the problem of the subepicardial abnormality. It's a problem in my opinion. But for the other localization, finally, when you can have a good position of the endomyocardial biopsy, in my opinion, you can put the biopsy and in the same time you practice the genetic development, and after you discuss with a colleague because it's really frequent to have the complete genetic pattern no in relation with the phenotype, and my colleagues say, oh, it's normally it's for the QT large QT and no for this disease it's not in a relation, it's not no, it's not that, probably it's effectively a no in relation for the phenotype, and you can decide this is a cardiomyopathy. And after there is a problem of the chronic myocarditis. In my opinion, it's not really so rare. It existed, and for that, the biopsy, it's really interesting with anatomopathology to see the different elements, immunohistochemy and anastomo, to have a clear definition of the and finally the treatment is also different in function of the viral replication. All elements is important. Is there really a overlap with different disease, and I continue to say it's interesting to have the information of anatomopathology in complement with the genetic.
Thank you very much for this nice discussion of the last case. I would like to thank everybody who joined this webinar, especially those who presented their cases and the panelists. We have discussed two very nice cases. The first one about the importance of an accessory papillary muscles for the mitral procedure. And we have learned that this papillary muscles are not that rare and that they might be important for the entire procedure. And the second case, we learned that there are new procedures that combines deep learning strategies as well as CMR to help us in guiding endomyocardial biopsies, especially for ruling out sarcoidosis. So I wish you all a nice day and thank you for the discussion and joining this webinar.
Thank you.
Thank you very much.
Thank you.
Thank you.
Bye.
Bye. Bye-bye.